Thank you for the introduction, Mr. Chairman. I'm a radiologist by training. DCE MRI the mathematics of DCE MRI has been described in journal publications, but it's actually not well explained to people who are not well versed in mathematics. I have no disclosures, and I hope to introduce DCE MRI to you to explain the tracer kinetic modeling equations, introduce you to different types of models, and show you considerations that are unique to the liver, and discuss some potential clinical applications, which there are few. As you know, DCE MRI is not ready for mainstream clinical use. Radiologists are familiar with dynamic imaging. They are familiar with the wash-in and wash-out pattern of hepatocellular carcinoma and of the delayed progressive enhancement of cholangiocarcinoma. When they make that diagnosis, they are actually mentally plotting the concentration time curves in their minds. So the tumor concentration time curve is actually a very useful parameter, and it allows the radiologist to make a diagnosis. DCE MRI stands for Dynamic Contrast Enhanced MRI, and it's different from the clinical dynamic MRI. Instead of 3 to 5 time points, rapid scans averaging every 2 to 4 seconds are performed over 5 minutes. And quantitative maps of the microcirculation are derived. Maps of blood flow, of the permeability surface area product, of the percentage of the voxel that's occupied by plasma or intravascular space, and the percentage of the voxel that's occupied by the extracellular space or the interstitial space. So this is what we are trying to image, angiogenesis. Angiogenesis occurs in cancer and in inflammation. New vessels are formed. There are too many of them, and hence a large proportion of the voxel is made up of intravascular volume. The flow is too high because there are no high-resistance arterioles. The basement membrane is absent, and there are large pores in the capillaries, which means that there is increased permeability. So that's what we hope to image with DCE MRI. I'm sure you must be thinking, well, Dr. Thng, if you want to image blood flow, why do it with a complicated modeling technique that I don't understand? Why don't you just inject a tracer into the bloodstream? Okay, this tracer doesn't escape from the bloodstream. Let's see how fast it passes through the tumor. We know if the tracer is of high concentration, it looks bright. If it goes in really fast, the gradient is high. And yes, you can do that. In fact, that has been done with various tracers, and that's the basis of dynamic susceptibility contrast imaging with the first pass effect, and that's also the basis of arterial spin labeling. But you can only get parameters that are related to the vascular space, like blood flow, percentage intravascular volume, and the mean transit time. You have no information about the permeability and the interstitial space, just because your tracer doesn't go there. So you might be thinking, well, but you just told me, Dr. Thng, that these vessels are leaky. Now, why don't we do another experiment? Now, let me send in a particle that leaks out of the capillaries, but in abnormal capillaries, but not in normal capillaries. This way, the faster it leaks, the higher would be my signal, and I would be able to determine the permeability. Yes, that technique has been done, but can I ask you, when you image, you are trying to image what is leaking out into the interstitium, but the signal that you are imaging, is it confounded by the tracer that remains in the blood vessels? I'm sure your answer is yes. You might be thinking, well, why don't we do a subtraction? We had previous measurements, so now let's just do a subtraction. Yes, and that has been done too, but can I ask you then, will your large particle tracer go into the small vessels? The answer might be no. So hence, the technique is confounded. Well then, allow me to make a proposition to you that we can measure not only blood flow, but permeability, as well as intravascular and interstitial space with just regular low molecular weight gadolinium contrast. But first, you need to indulge me with your attention by performing some thought experiments with me so that I can explain to you that the tumor concentration curve is actually a convolution of the arterial input function with the impulse retention function. So imagine that we can inject instantaneously a known amount of tracer into an arteriole and image this voxel repeatedly as the tracer passes through the tumor, leaks out and passes away from the tumor. But because our imager images the entire tumor and cannot resolve the individual spaces, the readout is actually 100%. It's only when the tracer flows away from the tumor that we get a sudden drop. And this drop depends on how much tracer has leaked out. And this is actually your first pass extraction fraction. So what I've just described to you mathematically is known as an impulse. This is actually mathematically an impulse. And subsequently, at this point in time, the decay of the tracer from the tumor is dependent on the permeability and the blood flow. The higher the leakiness, the more the tracer will leak in, and the higher the flow, the more it will be washed away. So hence, what we are imaging here is actually how much tracer is remaining in this system. And therefore, it is how much the impulse is retained, and hence the impulse retention function. So this impulse retention function actually tells us a lot about the microcirculation. If the permeability is high, a lot of tracer would have leaked out. Compared to what I showed you earlier, the takeoff would be higher. If the permeability is lower, less will have leaked out, and this would be the shape. Similarly, the washout depends on the flow and the permeability. A very gentle curve if the flow is low, and a very steep curve if the flow is high. So if only we can inject an impulse into arteriole, that will solve all our problems. We just need to image the impulse, image the tumor, and that will give us the impulse retention function, give us all the information that we need. But we know that that's not possible. What goes into the patient is actually a curve that looks like this, the arterial input function. But fortunately, that's where mathematics comes to our rescue. Because this arterial input function can be considered as many impulses separated by a small regular interval of time. So the impulse retention function of the tumor, as you know, is fixed. It depends on the permeability and the blood flow and the intravascular spaces of the tumor. And therefore, what happens is that when the first impulse enters the system, we will image it here, but then it decays in accordance to this shape due to the properties of the tumor. When the next impulse comes in, there is actually already a signal from the earlier impulse that has decayed in accordance to this decay, and here's the amount that is left behind. Let us then add them together, and so therefore we'll be imaging this and this. Then this second impulse then will decay, but by the time the third impulse comes in, there is actually tracer left behind from the first impulse. Let's add them there. The second impulse, let's put it there, and of course the third impulse, and that's what we are measuring. So hence, and of course the third impulse will decay in accordance to the IRF. So what we are actually measuring is actually a sum of what is retained by earlier impulses. And this mathematically is the mathematical operation of convolution. So now that we understand that, the tumor curve is just a convolution of the arterial input function with the property of the tissue, that's the impulse retention function. So what we do is that this impulse retention function, we can write an equation that models it. It can be modeled with the flow, permeability, intravascular space, and the interstitial space, and it will give us something that looks like this. Then what happens is then the computer takes over. It does the convolution repeatedly, and when it does this convolution, it will get a calculated tumor concentration time curve. It will try to fit that calculated curve with the actual observed curve, and the one that gives the best fit will give us the parameters. So I'm sure some of you might be thinking, well, Dr. Thng, that's great, but you haven't explained to me what is Ktrans. I keep reading about Ktrans all the time. Okay, what is Ktrans? Okay, in order for me to explain Ktrans to you, I need to take you through the equations, because Ktrans is a simplification of the modeling equation. So if you please bear with me, do not be intimidated by equations. These equations define the impulse retention function, and they are based on principles of mass balance and mass transfer. That tracer is transferred between compartments, but is never created nor destroyed. So first thing is to understand the basic conventional compartment model. This is the basic model. So what this model does is that it assumes instantaneous mixing. When the impulse goes into the arteriole, it is instantaneously mixed and it gives a uniform concentration in the vessel. This simplifies calculation because there's only now one concentration to calculate. And similarly, when it flows out into the interstitial space, there's instantaneous mixing and there's only one concentration in the interstitial space. So modeling is performed by equations that reflect the change in concentration in the vascular space as well as the interstitial space. So let's go through the equations. So let's take the first one, the vascular space. Okay, let's rearrange the equation so that's easier for us to understand. Okay. Now, by convention, when physiologists measure flow and permeability, they give the results in terms of volume over time, mils per minute or mils per second, per volume of tissue. So this equation includes the physiological measure, but in order for us to understand the mass balance and mass transfer, we need the actual permeability and the actual flow. Therefore, we should multiply by the volume of tissue. We should multiply everything by the volume of the actual voxel to get the actual flow and permeability. So the VP is actually the percentage of intravascular space or the plasma space. And when you multiply it by the actual volume, you will get a volume. Now, concentration here is actually mass divided by volume. When you multiply the two together, you cancel this and you cancel that. It's actually mass divided by time. So hence, this term reflects the mass in the vessel. This term, the next term, refers to the concentration of the impulse that enters the system. But when you multiply the concentration with volume, you get mass. And so it's the mass from the impulse and what happens to it. You expect it to decrease when it flows out of the vessel. So what is permeability surface area product? It's actually against flow across the vessel. So therefore, it's volume divided by time, multiplied by concentration, which is mass divided by volume, cancel, cancel, you get mass divided by time. As you can see, the equations are consistent. The mass in the vessel is due to the mass coming from the impulse, leaking out into the interstitium, flowing away, and mass entering the capillary from the interstitium. So let's work out the second equation. So for the second equation, similarly, we have to multiply by volume, and this again will give us the volume of the interstitial space. Sorry, there's a typo. And if you multiply that by concentration, then therefore you get mass. And similarly, this is actually flow, which is volume divided by time, multiplied by concentration, which is mass divided by volume, cancel, cancel, and you have mass divided by time. And therefore, the mass in the interstitium is due to the mass flowing from the vessel to the interstitium minus the amount that is flowing from the interstitium into the vessel. So these equations are consistent, as you can see. Now, you can make them more complicated by using another model called a distributed parameter model, or you can make it simplified by using the Ktrans or the generalized kinetic model. Let me explain the DP model. It's easier to explain. So this is what I showed you earlier. The distributed parameter model says that no, there is no instantaneous mixing. The concentration is higher at the arteriole, and similarly, the concentration in the interstitium also shows a gradient. So the concentration is actually different for every point, every Z point along the vessel. So as you can see, the complications, the equations are complicated. But because the mean transit time of tracer through the liver is 12 seconds, and we can image every 2 to every 4 seconds, we feel that there's actually enough temporal resolution to discover this gradient. So what about Ktrans? So this is the conventional compartment model, and this is the Ktrans equation. In the Ktrans model, it is assumed that, it is also called the generalized kinetic model, it is assumed that the intravascular space is negligible and hence 0. Hence the percentage of intravascular space is 0, and hence this whole term is wiped out. As you can see now, this equation resembles this equation. Before you jump in and say Ktrans is the same as permeability surface area product, the problem is that we have we have just assumed that there's no vessel in the system, but we know that there are vessels in the system. So this is not really a permeability measure. So we give it a name. We say it's a transfer constant. But what does it really do? So the thing is, according to the generalized kinetic model, Ktrans would reflect permeability under high flow conditions, and it would reflect flow under high permeability condition, and it would reflect a mixed under mixed conditions. So as you can see, Ktrans simplifies the model. As a result of the simplification, the impulse retention function is actually just a very simple exponential curve, and it doesn't reflect what we know actually happens in the capillaries. So which model then should you use? Well, it really depends on trade-offs. If you use a more complicated model, you have to acquire a higher temporal resolution. And with this good acquisition, you are able to calculate with the conventional compartment model and the distributed parameters model. The same data can also be used to calculate Ktrans for standardization and comparison with other studies. And this, the complicated model does give you parameters with physiologic meaning, but however, you may have a trade-off of coverage of the entire organ. So we perform a study in patients with colorectal cancer, and we found actually that the parameter that correlated with clinical outcome is the interstitial space that's calculated by the detailed distributed parameter model, and not the one that's calculated by the conventional compartment model, and not the one that's calculated by Ktrans, nor a commercial model. So I'm sure some of you might be thinking, thanks, Dr. Thng, but really I don't understand. And people have published with shapes of curve. Why can't I just do that? Okay, yes, you can, but what does the shape mean? So we did a study with neuroendocrine tumor, and when we used the distributed parameter model, we found that a wash-in and wash-out pattern shows tumor with higher intravascular space than interstitial space, and the progressive enhancing pattern shows tumor with higher interstitial space compared to vascular space. This is concordant with our clinical knowledge. So regarding the parameters of the curve, what we did was we did a simulation study, and we found that actually if you were to use any of the parameters, please use the maximum slope as that correlated with blood flow. And that slope is actually used in the hepatic perfusion index. So what about area under the curve? Well, IAUC stands for initial area under the curve, and you can calculate that for the 60 seconds or 90 seconds. And if it's normalized, it is just that area divided by the same area of the aorta. But what do these parameters mean? So when we did simulation, we found that actually you should use the IAUC, not of 30 or 60, but of the entire duration. If you divide that with the aorta, it actually correlates with vascular plus interstitial space. And alternatively, if you just use the last time point, that also correlates. So time is running out, and with the special considerations to the liver, suffice to say that the liver has two inputs, and the vascular space has a lot of large fenestra, and the tracer flows freely. Actually, in normal liver, it's all just vascular space. And when you read articles, please check whether are they using one input, two inputs, one compartment, or two compartments. And in cirrhosis, there's sinusoidal capillarization, where the fenestrae are actually closed and basement membrane is late. And in this space of this, there's fibrosis. Hence, the interstitial space is not zero. And when we did studies with normal liver, we found that the normal interstitial space of the liver is zero, whereas in cirrhotic liver, the interstitial space is not zero. So currently, DCE MRI is used for anti-angiogenic therapy assessment in a research setting. There are many exploratory studies, but few conclusions. That's because this technique is heterogeneous. This also presents an opportunity for us to do more work. And here's a good summary of what has been done. And so I hope I've given you an understanding that DCE MRI is a heterogeneous technique. When you do use it, try to understand the model that's used, whether is it a one or two compartment, and whether is it a generalized kinetic model or a conventional compartment model. And for the choice of model, is a trade-off between coverage and good data analysis. And currently, the potential use in assessment is in the assessment of anti-angiogenic therapy. But the tumor concentration curve is so useful to the radiologist, it's hard to believe that quantitative parameters are actually not useful. So hence, there's actually opportunity for us to do a lot of work here. So thank you for your attention.